Good morning, everyone. Welcome you all for our Sunday CME. Today we have an excellent speaker, our specialist ophthalmologist and glaucoma specialist, Dr. Rajesh Dalvi, who is speaking on the topic management of glaucoma. Going back to doctor's academic background, doctor is having 21 years of experience from various hospitals in India and other countries and is specialized in surgeries for cataract and LASIK as well as glaucoma surgery. Dr. Delvi has got total of 4 fellowships post MS and DNB. Sir has completed 2 fellowships in succession in Canada on glaucoma and anterior segment surgery from the University of Toronto, Canada, and in refractive surgery and anterior segment under Dr. Howard Gimbel in Gimbel Eye Center, Canada. Dr. Delvi is performing LASIK, PRK, ICL surgeries, glaucoma shunt surgeries, and laser trabeculoplasties, in addition to the cataract surgery. Sir has 2 more fellowships from Shankar Nethralaya and Arvind Eye Hospitals, which are the premier ophthalmology institutes in India. And recently, Sir has got a US patent for a cataract surgical device also. Welcome you, Sir, for presenting the CME.
Thank you, Dr. Nima, for the kind introduction, and a very good morning to MD Sir, the medical directors, and all my dear colleagues. So today I will be talking on the topic of glaucoma, which is a very important disease today in ophthalmology. It is becoming a leading cause of blindness. So I would like to share my screen with you for management of glaucoma. Glaucoma Okay, so I declare Yes. Is this okay? Okay, so I declare. Yeah. So I declare no financial interest in the presentation. The objectives are to explain the types of glaucoma, to enumerate the options for glaucoma treatment, and to explain the risks and complications of the various medications and procedures that we have. Glaucoma, because there are many non-ophthalmologists in the conference, I'm just going to briefly go over glaucoma. Basically, glaucoma is the silent thief of sight, and when the pressure in the eye goes beyond that is tolerable by the optic nerve, slowly the optic nerve starts losing its ability to transmit the information. The neuroretinal fibers start dying. Millions of them are there, so slowly a few million die, and slowly the person becomes blind. It is a serious condition because it's a silent condition, and many a times it is the ophthalmologist who picks this up. So this is a normal retina that we normally see. As you can see, there is an optic nerve with a 0.2, 0.3 cupping. And if it becomes like this, as you can see on the right side here, this is a large cupping. This is what is glaucoma. This is what an ophthalmologist sees when he looks into the fundus or the retina of the patient. And that is when the person realizes, or the doctor realizes rather, that there is something wrong here. And this is how the retinal nerve fibers are. This is important for people to understand, even the non-ophthalmologists, because sometimes you may get a visual field test report. And as you can see here, it is divided into 2 hemispheres, superior and inferior, like there is a median raphe in the center. So when you see this is important because that means that the type of defect can tell you whether it is a glaucoma defect or a neurological defect, because if the person has got scotomas in the visual field, a person is saying that I cannot see, and you do a visual field test, many a times glaucoma is overdiagnosed, many a times it's treated as glaucoma when it is a neurological problem. So this layout of the retinal nerve fiber is important for the neuro-ophthalms and neurologists and other doctors dealing with, and if you ever come across such fields. So what we are doing is, generally it's recommended that the screening has to be done for everyone over 50 years. Generally in the 4th and 5th decade glaucoma starts. So it's good that in Ahalia we have got a non-contact tonometer. So basically each patient here, whether 50 years or under, is also screened. We are doing NCTs, and if you find that the pressure of the eye is above 20/21, that is a green, that's a red flag, and immediately we start evaluating the patient. Of course, even if the pressure is normal, we are supposed to see, and that of course the ophthalmologist sees in the retina. The family history is important. If the patient has a family history of glaucoma, then definitely it can be early onset. Diabetics, as diabetes is increasing in the society today, it is very important that we look out for glaucoma, because diabetics have a propensity to become glaucomatous earlier. Steroid users, there are people who are using steroids over the counter on their own for allergies, eye drops, and even people are using oral steroids. The oral steroids don't cause so much of a problem as glaucoma, but that has to be kept in mind. And of course, patient presenting with complaints. But the funny thing is that patient does not generally complain that I have got worse sight. There are no symptoms. Generally, the complaints would be mild, non-specific headache. Recurrently, if the spectacle number is changing, like every 6 months, the patient's number is changing. If a perceptive patient may see that, although he is 6/6 on vision when we test the patient may say that I cannot see well, like there is a contrast sensitivity issue there. So if you test properly and if you have a high index of suspicion, you may pick up a glaucoma. It has been often that we have seen glaucomas for a normal pressure because the patient is complaining and there is nothing wrong with the eye. So that is when you go for a visual field test and you realize that the patient has got a problem. Of course, in acute glaucomas, when the pressure suddenly rises, people will definitely have symptoms like pain, vomiting, colored halos around lights. I remember a patient in our casualty who had come like 1 or 2 years ago, and the patient had gone to 2 other hospitals in the city with acute abdomen. And when the patient was brought here, I went to the casualty, and here also they were planning for ultrasound of the abdomen, but they also called me because the patient also said that I have pain in the eye. It was a young Filipino lady. And I remember this very well, that the eye was red. And it was not acute abdomen, but it was an acute congestive attack of glaucoma. So just looking at the eyes sometimes not enough. Glaucoma can present in many ways. As I said, then I had to operate that patient. I had to do an emergency phaco, and her vision was saved and her acute abdomen disappeared. So this is how glaucoma progresses. As you can see, right down is the normal vision. Early glaucoma, because the thing is that because people have 2 eyes, even if your vision, the periphery of your vision is affected, it does not show up immediately. Like, you have to be really perceptive. So most people will complain when they come to this stage. So it is actually the job of the ophthalmologist to make sure that the screening for NCT, that is the non-contact pressure, and even otherwise has to be done, and the retinal check has to be done, because if you catch this early, the person has a longer chance of good vision in life. This is the tonometry that we routinely do. These are some reports some of you may have seen. This is the OCT, which shows a computerized version, and it shows measurements in microns of the retinal nerve fiber. So as you can see, if at the top you may not be able to see easily, but generally if the patient has got a thick retinal nerve fiber like 90, 95, 100 microns, then it is good. Of course, this has to be interpreted in clinically correlated, but generally this is used as a test for repeated, means we do it every 6 months, 1 year, and if there is any change, we know that there is progression. So this is even before the visual field changes, even before the patient perceives any change in vision, we can pick up glaucoma because of the OCT. These are how visual field defects look. This is a classical glaucoma defect. As I showed you earlier, the retinal nerve fibers are divided into superior and inferior hemispheres. So this cutoff line, as you can see, is horizontal. So this is glaucoma. But if you have this kind of a picture, many of us know this during MBBS also, like hemianopias. They can also present with defects like quadrantinopias and hemianopias, and these are not glaucoma. So sometimes these can be misdiagnosed. So what basically the rule of thumb is that if there is a vertical meridian, it is neurological, and if the meridian is horizontal, it is glaucoma. So basically, coming down to glaucoma, most of our ophthalmologist friends know how to treat glaucoma medically, and they know that there are surgical options. But today I'm going to take a different approach. Instead of going by the book and telling that, okay, these are the types of glaucoma, these are the types of surgery, I'm just trying to go backwards. Like everybody knows these things in our ophthalmic world. So I want to just remind people that when a glaucoma patient comes, it is very important to know whether it's open angle or closed angle glaucoma. I have seen cases where the gonioscopy has been skipped, and because the pressure is like 40, 50, we just refer the patient, and I've seen the patient. But it's very important because whether it's an open angle or closed angle, that is so crucial to determine how to proceed, whether it's going to be a good case or bad case. In fact, open angle is not really a good sight to see because that limits your options for surgery or lasers. Closed angle means that the patient is probably developing a closed angle. You do a iridotomy or a iridoplasty, or you do a cataract surgery, and the patient will recover. But in an open angle basically means that the patient has a normal looking eye, normal anatomy, and still the patient has glaucoma, so your options are limited. So knowing the angle is very important. Acute or chronic, obviously, in acute glaucoma is easy to treat because the patient comes with complaint, but comes with complaints. But the chronic glaucoma is the one which is a challenge. So an open angle chronic glaucoma is the one which we have to screen and catch. Primary and secondary glaucomas, we all know that the glaucomas which occur de novo, we call them as primary. And suppose there is uveitis, secondary again here. So knowing that it's a closed angle or open angle, knowing that it's acute or chronic, first you have to categorize the glaucoma before starting, even before starting treatment. Before starting it, you have to plan it in your head that, okay, I have a closed angle acute glaucoma which is secondary to this, so probably I have a different plan. I have an open angle chronic glaucoma, that means it's going to be long term. And glaucoma patients are not patients that get cured and go home. Unfortunately, the open angle ones, they always stay on eye drops most of the time, and it is a long haul. Like once a glaucoma patient starts coming to you, it is the responsibility of the surgeon to make sure that his vision stays there for years together. Like with the increasing lifespan, it is becoming very important that these categorizations have done right in the beginning, and the plan is not for 10, 5 years or something, but 20, 25 years, 30 years. Unfortunately, with diabetes, the age group of glaucoma is like 40s now, so it is a real challenge. But thankfully, we have the lasers here. We have all types of lasers in Ahalia, and we are doing SLT laser and cyclo photocoagulation and everything. So we have options, and of course, juvenile versus adult onset. Juveniles are difficult to treat because there is dysgenesis in the angle. So categorizing the glaucoma is primary before you even start thinking about treating. Um, this is important that gonioscopy is done after the IOP is taken. If you do the gonioscopy before the IOP is taken, you are going to get wrong readings because the positional gonioscopy itself can cause the pressure to drop down. And as you can see, you have to know your angle well. One thing about the open and closed angle is it's not so simple. There is something known as plateau iris, which I'll come to later. So we have to know where the laser iridotomy, which is done in closed angle, works and where it does not work. Because if you do a laser iridotomy uh, without knowing that it's a closed angle or it is plateau iris, then you are unnecessarily subjecting the patient to an extra hole in the eye and maybe glare and other symptoms. So knowing your angle is very important for a glaucoma specialist. Now, setting the target and lowering the IOP, everybody knows the first thing, the only thing that we can do is lower the IOP. There's not much that we can do in terms of improving the resistance of the retinal nerve fiber layer, though eye drops like brimonidine and all were touted to have improve the resistance of the nerve fiber layer, but this is primarily what we do. The early treatment trials that we had, the OHTS and the ocular hypertension treatment study, which showed us that it is useful to reduce the pressure initially rather than wait, because in these trials they did not start treatment for patients even with 23 millimeters of mercury and over pressures, and they just kept observing. And it has been shown that it is of great benefit, especially at high risk individuals. So if you have a high risk individual who has diabetes and a high pressure, just because he does not have any visual field defects, it's not like you treat the patient like ocular hypertension and keep him on a watch. It is better to start some treatment and bring down the pressure. And The other thing, the EMGT trial showed that a 25% decrease of IOP from baseline reduced the progression by 50%. So this all ophthalmologists know, but many more things have added to these trials now that basically even if you reduce the pressure by 25%, still the glaucoma progresses. This was seen in the trial in some cases. And in that case, we need to customize the treatment as per the patient. So I have patients who require pressures in the single digits, like 8 millimeters of mercury or 10 millimeters of mercury, especially if their cupping is 0.9, 0.95 or something. So 25% decrease is the basic thing. Beyond that also you have to do. I know that there are patients who have 14 and 15 pressures, and many doctors may think this is normal, but I want to reiterate that 14, 15 does look normal, but many a times it's not normal. Sometimes you have to do the pressures right up to, bring the pressures right up to 8 or 9. And with all the equipment we have, we do try to do that, and you have to maintain it at 8 or 9. It's just not getting it one shot, because as I'll come to later, that trabeculectomy also has high rate of failure. So it's not the golden standard, in the sense it's the end all of it. You have to keep looking at these patients every 6 months, 3 months, depending on how bad the case is. So basically, glaucoma is a very dynamic disease, and it is, the challenge is to keep the person visually capable for long years, like 20 years, 30 years, and to keep his pressures down in the target range. Achieving the target is not so easy anymore. It can be from anywhere from 8 millimeters mercury to 16 millimeters of mercury. Mostly we try to keep it around 12 for advanced cases, but I have seen cases we have to reduce it further. So these things have to be taken into account. And how do you manage that? You repeatedly do tests every 3 months for the advanced cases. You do the visual fields, you do the OCT, and if you find that there is progression, then you go ahead and add the drops, or you do a surgical procedure, or you do a laser, but this is a very tight control. So the management, what are the options we have? Medical, lasers, and surgical. We have all this in Ahalia. And what are the pros and cons of the group? So basically there are 5 groups of eye drops. This is the first line of treatment. Most of the times the patient comes, we will be giving beta blockers, carbonic anhydrase inhibitors, myotics, prostaglandin analogs, or alpha agonists. Now the main thing is, many a times the question is in the exam, which is the drug of choice? Now, as my experience as a glaucoma surgeon is that it is not that which is a drug of choice, it is rather the other way around, which is a drug that is going to cause complications and you will not give the patient. So rather than looking at the drug of choice, you look at it at the other way around. For example, you have beta blockers like timolol. It is a beta blocker. So if the person has got asthma, or the person has got some cardiac issue, you will think twice before giving timolol. I remember of a patient, I had started on timolol, this was like 10 years ago, and the next day the patient was quite educated. He came back to me and said, I had chest pain and I had some difficulty breathing, so I stopped the drop. Doctor, was it responsible for it? Yes, it probably was. It was a beta blocker. So when we give drops now, at least when I give drops, I first look at the indications for not to give, so that I do not land in some other trouble or systemic complication. So you have to know what you're giving, like carbonic anhydrase inhibitors, acetazolamide and all. There are indications to give and not to give. So first you rule out what you will not give. And knowing the special side effects of each drop is important, like patients who have been on brimonidine, or who have been on prostaglandin analogs like travoprost, they suddenly develop red eyes. You have to discuss with the patient. Some patients develop pigmentation around their eyes, which is known as raccoon eyes. It doesn't look good. So some patients, you have to actually tell them that, would you be okay with this? Because these are side effects that are not known to the patient, and then they come after 3 months with eyes with dark circles, and then it's always better to discuss this with the patient. So first rule out what you do not want to give, and then decide what you want to give. So for example, in a Parkinsonism patient, you will not give pilocarpine. It's a cholinergic drug. For a patient who wants to go LASIK, you will not give brimonidine, because brimonidine causes slippage of the flap. If a patient is latanoprost, I would like to say one thing is that these prostaglandin analogs are very popular, considered the drug of first choice, but in women who are of childbearing age group, you have to make sure that the patient is not planning pregnancy, because it can cause, there are some studies which show, so because it's a prostaglandin, it can cause issues, it can cause abortions. So the beta blockers for asthma, as I mentioned before, suppose the patient has an anterior chamber IOL, then brinzolamide, because these drugs, the carbonic anhydrase inhibitors, also act on the endothelium, which has got a HK pump, so then hydrogen potassium pump, so that gets affected. So these are this is how I would approach a patient of treatment. So my choice many a times comes with a beta blocker rather than the latanoprost, because many of these patients are 50 plus who are already on beta blockers orally, so I don't see a risk there. And many a times monocular treatment, you do not want one eye like a raccoon eye and the other eye normal. So those are the reasons. Every surgeon has his own theory behind it, but over my experience, I have come to this conclusion. And the lasers, we have these: argon laser trabeculoplasty, SLT, transscleral cyclophotocoagulation, endolaser photocoagulation, iridotomy, and iridoplasty. Now, lasers have the great advantage. Remember one thing, that trabeculectomy is best done in the first shot, because you have got a virgin conjunctiva, and the surgery when you do first time is the best shot you have to give the patient a fantastic result. But trabeculectomies before the advent of MMCs and 5FUs have been known to fail, like up to 60-70% of TRABs would fail in the first year. So you want to go and do a TRAB right away? No. Means at least I would believe that you try with the lasers, you try with the eye drops, you probably even try with cataract surgery before you touch the conjunctiva. The conjunctiva has to be pristine, and once you operate that, then that TRAB has to stay, because if it fails, then the second chance, means the second surgery is, means of course you will do a supranasal TRAB, allowing for another second TRAB supratemporally. But it is very important to know your lasers, and when you know your lasers, you know your angle. You have to know your angle properly. If your gonioscopy is not perfect, then you will not be able to do a laser trabeculoplasty. So there are types of lasers we are doing. YAG laser iridotomy is the commonest, which is for angle closure. Retinal laser PRP is indirect way of treating, like NVG, neovascular glaucoma. When you do the laser for the retina, the NVG is treated, and I've had patients like this. I've referred to my retinal colleague about 1 year ago. I remember a patient that first it was so bad that the NVG, that we first did the laser, and after that, after a little treatment, the patient was okay. One patient I of course operated, but NVG operations are again bound with the risks. So it is better that you use the lasers first. Don't rush into surgery. Curative is like SLT, iridotomy, iridoplasty, especially SLT is for open angle, iridotomy plasty is for angle closure or for plateau iris. Transscleral photocoagulation is good for higher pressures like 30, 40. With a micropulse, it has been useful in many cases to bring down the pressure in target range. Miscellaneous, like there is nothing known as tertiary glaucoma in what we are taught, but I believe we can discuss that. Like NVG is known as secondary glaucoma, but I had a patient, I'll come to that, who had uveitis causing glaucoma. So you would categorize that as secondary glaucoma. But the patient had rheumatoid arthritis. So the rheumatoid arthritis caused the uveitis, that caused the glaucoma. So it was not one thing. It was like a tertiary or quaternary kind of glaucoma. And the steroids, when you started the patient on steroids, the pressure would rise. So that case I'll discuss. So these kinds of glaucomas are there, which you have to treat the systemically. It's very important to take proper history. And there are miscellaneous causes, like, as I mentioned, uncontrolled diabetes causing glaucoma, and neovascularization causing glaucoma. So you have to look out for this. Many a times neovascularization is missed, especially if it's in the angle. If the iris does not show NVG, then people don't look at the angle. So again, I'm coming to gonioscopy being so important. And post-pterygium, whenever we are doing a lot of pterygium surgeries, so we have to be careful about this. If you are doing a pterygium surgery for a patient who is in the age group of 50, 40, something like that, we have to be careful, because if this patient has tendencies of diabetes, glaucoma, then maybe we should not use autoconjunctival graft. Maybe we should be using some other graft, because autologous graft, because these patients tomorrow, if they require trabeculectomy, then you will have a messed up conjunctiva you could have. So it's better to avoid. And combined cataract surgery. And many of the trabeculectomies, after you do trab, I have observed, and it's a known thing, that cataract does develop at some stage. So maybe doing a cataract with the trab. Of course, there is an issue of whether you can do a RLE, like a clear lens extraction, but yes, that would be a better option, I feel, because it reduces the number of surgeries, and it also improves the control of the IOP because of the cataract surgery. So you have to take a holistic view. I'm trying to discuss 3 interesting cases that I have had here. the importance of SLT. SLT is not used by many surgeons. I have seen that selective laser trabeculoplasty is not like used by many surgeons because the pressure drop in the SLT is like 4 to 5 millimeters, and people think it's a waste. You can either put eye drops or directly go for trabeculectomy, but it's not so. I remember 3 cases I handled here. One was intravitreal steroid injection was done for macular edema. The pressure went to 40, and with Timox and all, it was controlled to 22, 23, and it wouldn't come down. And of course, the first this thing would be you go for surgery, but because it was a steroid-induced glaucoma, I didn't do that. I just went for SLT, and you will be surprised to know that although SLT has shown 4 to 5 millimeters mercury drop in cases of steroid-induced glaucoma, it was wonderful. The pressure went to 16 from 40, and the patient was fine. Means there was no issue. Afterwards, with a couple of eye drops, the patient was settled. We did not have to do any surgery for the patient by selective laser trabeculoplasty. Just one sitting of selective laser trabeculoplasty. That is because of the theory that the steroids go and cause glycosaminoglycans to accumulate in the angle, and once you do the SLT, it disrupts the angle and it reinstates the trabecular meshwork. And although there is different theories of it, but it did work in this case. Also, another case, there was an intravitreal steroid done during anterior-vitrectomy. Same thing. Patient was lasered also. Transconjunctival laser was done, but the pressure still stayed to 40. And after that, I did a SLT, and the pressure dropped to again in the 18 or something. So it was wonderful. And the third case would be a case of uveitic glaucoma, which I discussed earlier. This patient was on anti-glaucoma medications for 3 months. Had been to another hospital. He had high uveitis with +4 flare. So you had an eye which had a first +4 flare, uveitis not responding to steroids, and steroids causing glaucoma. So uveitis causing glaucoma and the steroids causing glaucoma, so you cannot actually treat the uveitis properly. After detailed history, I realized that the patient has got rheumatoid arthritis for which he was taking some herbal medication, and he had stopped 1 year ago taking any oral medication or allopathic medication, and his joint pain, everything was up. So this was the kind of glaucoma. I said that one thing leads to another, and another thing leads to a third thing. So first, what I had to do is I had to send him to a rheumatologist. He was treated with methotrexate, and associated with that, oral steroids were started. But unfortunately, his uveitis wouldn't come down. His cupping was 0.8, and he had already, when visual field test was showing excessive loss of vision, and it was 3 months too late. So finally I decided to go for trabeculectomy. The trabeculectomy served 2 purposes. Firstly, immediate reduction of pressure to prevent further loss of vision. Secondly, release of all the inflammatory cells in the antechamber. Thirdly, because you have a TRAB bleb, any spikes in IOP are taken care of. So even if you give steroids after doing a trabeculectomy, it's okay because there is a TRAB, there is a bleb. So the steroid-induced pressure rise will be taken care of by the TRAB. So we did this. After a week or 2 weeks, the patient had a quiet eye. But then I had another problem. I had given him a small tricot depot injection because he had severe uveitis, and he started bleeding because tricot also causes conjunctival hemorrhage. So I had to remove the tricot. After that, what happened is that although there was a shallow bleb, it was not a very big bleb. The pressure was okay for some time. The eye was quiet, and suddenly the pressure started rising. Why did the pressure rise? Steroid-induced glaucoma. So after doing a TRAB, after doing all this, I went ahead and did an SLT on this patient, and his pressure, which was at 24, came down to 16, and now he's doing fine. Not to mention that these patients are at risk of a little bit of cataract, which is developing in his eye. So you have rheumatoid arthritis, you have uveitis, then you have steroid-induced glaucoma, then you have cataract, you have secondary glaucoma. There are so many things. So really, when you are managing a glaucoma patient, you have to think all this through. And if you do a cataract for a glaucoma patient, as this patient had high myopia, so now you have to account for anisometropia. So if you go for cataract, you have to account for anisometropia. So you really have to take a full picture of what all can go wrong and what all you should not do to prevent further complications. So the plan has to be complete. I just wanted to make a point about that. And the point about usage of this SLT laser, which is very, very useful, especially for these kinds of cases, like steroid-induced glaucoma, preventing any unnecessary further surgery. So this is what you see. This is how you see the angle. When the 2 visible lines come together, this Ralph's line, this everybody knows, and just reiterating a point. Now, one thing is that I would like to show this. This is a picture of a plateau iris. So when you are looking at the angle, If we have a UBM, then you can do a UBM. This shows that this iris is forward and there's a larger ciliary body. In clinically, when you are looking at the iris, suppose you have a young patient with a narrow angle and you are keen to do an iridotomy, maybe it is better to do a gonioscopy, and you have this double hump sign, as you can see here. There's a bump here, hump here, and a hump here, and the depression here, and then there's the angle beyond the second hump. This basically means that the patient has got plateau iris. So your iridotomy is not going to work. So you just go ahead and do an iridotomy. It's going to give a patient an extra hole in the eye, maybe come with glare complaint and all. So it is not a very good thing to do. First you do your gonioscopy, check for this, and then you can go for iridoplasty rather than iridotomy. So what are the surgical options? Suppose you are exhausted with your lasers and eye drops, then the surgical options are trabeculectomy, shunt surgeries, and minimally invasive glaucoma surgeries. Trabeculectomy still is the gold standard in the sense that it is a surgery which is readily available to be done, and the complication rates of trabeculectomy, though they are there, the shunt surgeries are pretty difficult to follow up, and they also require it to be a primary open angle glaucoma. You can't do it in closed angle glaucoma. So in that way, trabeculectomy still stands out. We have IFU, we have mitomycin, we have express shunt, we have so many things to help us with the trabeculectomy to make its longevity more. But once you are exhausted other options, you can go for trabeculectomy. This is how we normally do it. Not to explain, this is a standard surgery. Only thing is that collagen implants or using an express shunt does help in the results. And using the technique of laser suture lysis, I would recommend that because again, the lasers are used. This really helps you if you can do laser suture lysis. It really helps you titrate the pressures. So you do a surgery, you're not worried about hypotony or hypertony because you can do a laser suture lysis and then titrate the pressure. So all these additional adjunctive support is required when you are doing trabeculectomy to give a better result than what was there 20 years ago. Shunt surgeries are indicated in end-stage glaucomas. The shunts that I have been doing was basically I would do the Ahmed valve, but there are other like Baer valves and everything. Shunt surgeries have a problem. You need a pristine cornea, a conjunctival fibrosis, or a failed trap is although in failed traps they do shunt surgeries, but if you have conjunctival fibrosis and all that, then it becomes a little difficult. But generally, traps when you are doing, do them supranasally, supratemporal area. You can leave knowing that if something fails, you can do a second trap or a shunt surgery there. Target pressures are better achieved with shunt surgeries. If you have a valve shunt like the Ahmed valve, then it is better. You do not have hypotony. In the Baer valves, of course, you can have a severe hypotony. So Ahmed valve, I believe, is more popular. But now with new techniques and with lasers, even shunt surgery numbers are decreasing nowadays. These are the shunt. These are different models. As you can see here, this is the location. This is the shunt. The tube goes into the antechamber, and this is how you put it into the superior temporal region. And post-operatively, as you can see, this is a tube, and this, as you can see here, is the bleb. What is basically a shunt surgery? Nothing but to make a reservoir to collect the extra fluid from the eye, to decompress the eye so that the pressure in the eye is less. So what is the management of TRABS? Basically, it is important to manage hypotony in TRABS. It's the commonest, this thing is TRABS. As I mentioned before, it is better. I prefer to tighten my sutures to prevent any hypotony, because if you have choroidals or you have hypotony, that it becomes very difficult. So what I'm doing is releasable sutures. Initially, first few days, I let the conjunctiva heal. Once the conjunctiva is healed, then only you do removal of the sutures or suture lysis if you have a lens. The other problem is leakage of the wound. So these are the commonest problems with trabeculectomy, but if you are careful, and especially if your sutures are well sutured, many of the surgeons have this thing of putting two sutures. Basically, the popular mode is doing the fornix-based trabeculectomies, and many surgeons just put two sutures and they believe that the healing will happen. But experience has taught me that it is better to suture more. You do not want a single leak there. A single leak can damage the bleb. It can really cause a lot of complications and a headache. So meticulous surgery is of utmost importance in trabeculectomy. And the retinal complications, of course, they can happen on table also, like a hemorrhage and choroidal hemorrhage and all can happen. So monitoring the patients also after, it is a very intensive surgery. Your patients have to have time. If the patient is coming from far away, from 4 hours away from Abu Dhabi, then you have to tell the patient that, look here, you have to stay near in the city. You have to be able to come again and again, because these surgeries are not like cataract that you operate and leave them alone. You have to monitor them. Anything can happen from day 1 to day 30, even later on. But initial few days, initial 2 weeks are very critical for hypotony and leakage or hemorrhage and choroidals, or anything can happen. So this is a very intensive surgery which requires monitoring. The importance is this, that if your trap fails, then again doing it is onerous task. So very important. That is what brings us to minimal invasive glaucoma surgeries. We have these small, I wouldn't name which ones because of this thing, but these are the surgeries. We have small kinds of shunts which are inserted in the trabecular meshwork to bypass the trabecular meshwork. And these, of course, are not useful for reduction of pressure from 40 to 20 or something like that, but for 5 to 10 millimeters of mercury, these work well. And these are, this is known as minimally invasive glaucoma surgery. So with this addition, we are at a place where we have given many options to the patients. Mostly it's recommended that minimal invasive glaucoma surgery is done along with the cataract surgery, because you do not want to operate the patient twice, and it also helps to open up the angle. So these kinds of surgeries generally are multiple, like you are doing some sinuculisis or maybe a cataract with sinuculisis and putting the shunts in the, but these advances in glaucoma have been happening in the recent few years, and it is heartening that we have so many options now. So basically, how do you approach a cataract patient? You get a history, you look out for family history, you do a complete examination, you look for the optic discs, for the visual fields, for the target pressure, evaluate the side effects of everything. Even whether you are operating trabeculectomy, you look for side effects like conjunctival fibrosis, whether you have left space for a shunt later on, whether it's open angle or closed angle. If open angle, you can plan a shunt. If closed angle, you know that this is your surgery that has to be perfect. Maybe you would want to do lens extraction along with it, because after trab, if the patient develops cataract and you do cataract after the trab, then the lab fails. So it's a headache. So if you are going to do a trab, it's better to try and get rid of the cataract before or with, because after trab, if you have to do a cataract, then your nicely done trab is bound to fail. So these things are very important. Side effects, as I repeatedly said, whether you do surgery, whether you do shunt surgery, whether you do pterygium surgery, whether you do anything, you have to keep in mind what is going to happen 10 years down the line, 5 years down the line, because these are long-term patients. These are like life, they are glaucoma patients for life. So finally, this is how you evaluate the type of intervention. I'm just giving, it's a very vast topic, I'm just giving an outline. So when the patient comes, quick overview, immediately picking up that the patient has glaucoma. In this stage is when you have early glaucoma, when you do some lasers and you just put a couple of eye drops, things are well. The patient does not go to advanced stage where you are forced to do a surgery, because if a patient goes to the advanced stage, then the target IOP starts dropping. So if the cupping is 0.9, the target IOP is like 10. And the cupping is 0.6, the target IOP can be 14 or 16. So if you allow the cupping to progress, that means you are allowing the target IOP to drop. And when the target IOP drops, it becomes a bigger problem. So it's better to catch them early. Screening, as I mentioned before. So when to operate? Yes, there is one trial which was done recently, a couple of few years ago, and that's the EAGLE trial, which has actually the rest of the things I've discussed. The last you can see below is the EAGLE trial. The EAGLE trial was done with 805 patients, and they were randomized. 419 were randomized to, after seeing the eligibility, to 200 patients with clear lens extraction and 211 patients with just peripheral iridotomy. So it was seen that after the trial was done with the EAGLE study, it was seen that clear lens extraction was shown to have greater efficacy and was most cost effective than laser peripheral iridotomy. So if you have patients who are especially closed angle glaucoma, the first tendency is to do an iridotomy, which is fine, but it has been shown that if this patient is in the age group, I do not know whether clear lens extraction will be covered by insurance so soon, but at some stage we have to understand that clear lens extraction itself can be a treatment for glaucoma. So my approach to glaucoma has been non-interventional initially. You go for, if you have to intervene, then you do combined surgeries. Better to do them. Use your lasers to the max. You have to evaluate the patient as a person. You have to look at the diabetes. I remember a patient who came with 40 pressure, and she had lost 5 kgs of weight because of a keto diet. And when I evaluated her, I saw she had 400 sugar, and she didn't know she had diabetes. And we treated the diabetes. Angiogram was done for the retina. There was severe ischemia of the retina. So after reducing the sugar and after doing a PRP, the pressure automatically dropped down. She didn't have an NVG, but the pressure still dropped down in the 20s, and with eye drops she was controlled. So nothing was required. So having to know that the patient has something else like diabetes, or having to figure out that the patient has rheumatoid arthritis, which is causing uveitis, which is causing glaucoma. With steroids, it's causing steroid-induced. So you really have to stretch it out, and you have to find out what is causing the problem. And if you have a holistic approach, then you have a longer goal, like you can make the patient visibly fit for a longer time, for 20-30 years. If you just go ahead and do TRABS, left, right, center, then you are actually creating a problem, because patient eventually will require a second and third surgery, and they don't do always well. So that's what I would like to bring home the point. Uh, Thank you very much.
Thank you very much, Dr. Rajesh Dalvi, for the excellent presentation, covering all the aspects of glaucoma management and sharing his own clinical experiences. So the topic is now open for discussion. We have our ophthalmologist also, so who can add few points. Sir, I have one question.
Yeah.
Sir, now we see a lot of steroid responders in our OPD,
Yes.
because for the cataract surgery and the pterygium surgeries, we usually give the post-operatively, we give the topical steroids. Even with
Right.
topical steroids also, we, especially when they come after for the first post-op visit, their IOPs may be some 30, 40 in that range.
Yeah.
So for them, actually, the steroid drops are essential to
Mm.
control the inflammation. So
Yeah.
can you explain how will you deal with those cases? Sir, you are, sir, I think you are not audible. Some lag is there. Can you hear me, sir? Sorry, there is some lag is there in the audio. We'll correct it soon. So, as Sir has already clearly mentioned, glaucoma is the silent thief of sight. So, we also see a lot of cases of glaucoma, but they present to us in a different situation, having entirely different symptoms also. And on our routine clinical examination only, we are finding out that the patient, that is by our fundus examination, and we are finding out the patient is having a glaucomatous cupping. And then when we do the further IOP test, intraocular pressure testing and field defects, then only we are picking up many cases of glaucoma. And another important thing I want to highlight is, first a patient is diagnosed with glaucoma, then we have to properly counsel the patient. That is, just like blood pressure and diabetes, it is going to be a lifelong treatment. And the importance of regular follow-up with the doctor and the use of topical drops or whatever surgery has to be done regularly, and the frequent follow-ups has to be done. And another thing is, it is, since glaucoma has got a genetic association also, so the family members also to be screened for the glaucoma, because early detection is really sight saving. If it is, especially if the field defect comes, then we cannot retrieve the vision that is already lost. So the early detection is very important in the glaucoma management actually. So we can save our patient's vision actually. And the other way also, actually, that also we have seen. Not all cases are also glaucoma. Some cases on our routine examination, we may be finding, seeing the patient with a cupping, glaucomatous cupping, but their eye pressure is normal. And then when we take the field defect, so when a patient comes, we usually do the IOP testing as well as the fundus examination. And when we see a suspicious cupping, we order for the visual field and the OCT. Sorry. So in the visual field, actually, we saw a vertical field defect, and then we referred the patient to the neurology, and they took an MRI, and it was an intracranial space occupying lesion. So the other way around is also possible. So we have to have an open mind in diagnosing a case of glaucoma, and if needed, appropriate referral also. Okay, sir.
Hello,
Now, yes,
yeah.
yes, sir.
There was some technical issue. Yeah. So basically, yes, that's a very good question. We are seeing, just like we are seeing for diabetics now, we are seeing steroid responders. So not particularly to cataract, but I have one thing I do sometimes is that if it's a short duration treatment, like for 4 days, 7 days, in cataract also the first week is very important. And if you are seeing that the pride is causing a problem, then you can, like I'm not saying you have to, but you can either shift to low bread or you can take systemic steroids. So if the patient is non-diabetic, the patient does not have any chest infection like a tuberculosis patient or something, and otherwise healthy patient, by giving systemic steroids for a short duration, it works wonderfully well for iritis and everything. Like if you have some amount of uveitis associated with the surgery of cataract or uveitic cataract, you just give some steroids for like 1 week, and then you go to lotepred. So lotepred or something can control the IOP. And at the same time, you will not have a IOP which is rising. Tolerable, if the IOP is just rising up to 22, 25, then I would not bother too much. But if the IOP is touching 40 and plus, then I am a little worried. So you have to take it like that, because the steroids are required. You cannot avoid the steroids for the first week, and then you can just taper it off and just hope that the patient is okay on Nefafanac or something like that, and work, at least for cataract, I can say that.
Thank you, doctor. Then we have our ophthalmologist in the audience. Can you please, we have Dr. Anumeha, Dr. Ajay is there, Dr. Venkat is there. Can you please add few points to the discussion?
Hello. Hello.
Yes, sir, you are audible now.
I couldn't hear you. Did you ask something?
No, I actually asked our other ophthalmologist to add few points to the discussion. So any questions from the audience, please? Any doubt? So if no more questions, then we can conclude the session. So thank you again, Dr. Rajesh, for the excellent presentation.
Thank you very much.
And the post-test as well as evaluation are posted in the chat box as well as in AHH WhatsApp group. Please fill up the post-test and evaluation before concluding the CME. So thank you once again for participating in our CME, and see you all for the next Sunday CME. Thank you.